I know that I am live. Okay, great. I think so. I'm live. Fine. So a very good morning, everyone. I hope your weekend has started with me. So I hope the weekend goes well, so that you don't blame me for a bad weekend, right? As it was, I know that I am live. We are going to discuss a few PYQs from NEET 2018, right? So if you are free here, I want you to comment on the answers and let's discuss. Good morning, SB. Good morning, Avinash. Right? Okay, so today I won't have the 10 p.m. discussion. Like I said, I am having some important batch meet. We are meeting our friends for after a long time, so I won't be available for today and tomorrow. And we'll continue our discussion from Monday again as usual, right? So a few things to start with. The compete is there. The things are there. If you want to subscribe, you can subscribe with any code as usual, fine. So I'm going to discuss few PYQs which came in NEET 2018. I want a little bit of quick discussion. I want everyone here who's online to comment on the answer, and then we'll automatically go to some topic related to that, right? So it'll be definitely good for us. Yes, be reunion. Fine. Okay, let's go to the first question. I hope it's visible. I'm not completely obliterating the image, right? So can you guys comment on the diagnosis? The image is like this. Can you guys comment on the diagnosis? I want you guys to comment. It's fine if you're wrong. It's completely fine. We know the drill, right? I just want you to know the right. Tell me the right answer. Okay, SB has gone with A. B. Avinash has gone with A. Anyone else? I want others to also to participate here. It's a 40-year-old person presented with the neck swelling. The histology shows the below diagnosis. What could be the most probable diagnosis here? Okay, so we have a mixed option, right? C, B as well as A, right? None of you call follicular carcinoma. Okay, great with that. I don't know why follicular carcinoma has been left out. Now let's look at the question. Do you have any history, any clue from the question? Can I say almost all the four options given here can have the same history? 40-year-old presenting with the neck swelling, right? Definitely. So this is not providing me any clue at all, right? So 40-year-old with neck swelling will not help me to rule out any of the four options because all four options can have the same history, right? The only thing for me is my microscopy and the gross. When you look at the gross, can I say it's multinodular? Just for a starting purpose, it's definitely multinodular, right? So I'm having lots of tiny nodules. Here's one, here is one, here is one, right? It's multinodular. It's multiple to start with. At least to start with, it's multiple as nodular. It is a solid mass. It's not a cystic mass. It's definitely solid mass, right? So it's a solid mass and it's a multinodular thing, fine. So with this, will I be able to rule out Hashimoto's? Is Hashimoto nodular or is Hashimoto diffuse? I'm just going with few gross information. We'll go to the microscopy and it will help us to tell me what's the correct diagnosis. Hashimoto's in general, is it a diffuse swelling of the thyroid or is it a nodular swelling of the thyroid? Just with a gross image alone, I can kind of rule out Hashimoto because Hashimoto is a diffuse thyroid swelling. It's a lymphoid problem, right? It's an autoimmune disease, right? It's a diffuse thyroid swelling. It will not be nodular. It's very, very unlikely for a Hashimoto to have a nodular swelling. So I can kind of rule that out, right? I'm going to the options. I can kind of rule out Hashimoto's thyroiditis just with the gross imaging because I'm seeing nodules in the gross. I'm not seeing any diffuse uniform swelling, right? Other three can have nodular swellings, be it your medullary carcinoma thyroid or your anaplastic carcinoma or your follicular carcinoma will definitely have nodular swelling of the thyroid, right? Now let's go do one more information here. The option C, the anaplastic carcinoma. Anaplastic carcinoma of thyroid, what do you think would be the presenting feature? Will they present with a neck swelling or will they present with stridor and obstruction or dysphagia? In general, what do you think anaplastic carcinoma of thyroid will present as? Generally, they are extremely fast growing mass, right? Most of the time, anaplastic carcinoma thyroid, they are extremely fast growing mass. They can compress the underlying structure. They generally present with stridor or they can invade into the esophagus and they can present with your dysphagia, right? Generally, anaplastic carcinoma of thyroid will unlikely present as a very innocuous mild swelling of the neck, right? They generally present as dysphagia or a history of extremely fastly aggressive growing. So those are the pointers for anaplastic carcinoma from my history. That's not there. Not just that, if I look at this image, can I say almost every nucleus here is more or less having the same size and shape? It's not extremely anaplastic, right? To call it anaplastic, it will not be suffice for me to call it anaplastic. Anaplastic means I have a cell like this, I have a big cell like this, I have some cell like this, a cell like this, then only I can call it anaplastic. Anaplasia has loss of differentiation. It looks very weird. I don't have a cell like that here, so I'm going to ignore. It's not an anaplastic carcinoma of thyroid, right? I'll ignore that also with little bit of information we already know. There are only two more options left: follicular carcinoma and your medullary carcinoma of thyroid, right? Now with these two options, again we'll go to the image, because grossly I cannot differentiate is follicular or medullary. Microscopy will definitely help me to diagnose them. If it's follicular carcinoma of thyroid, I should see capsular invasion. In this image, I'm not seeing a capsule, neither I'm seeing follicles, but what I'm seeing is this substance. I'm seeing a pink acellular substance which is seen outside the cells, and it is not having a particular shape. It's an amorphous thing, right? So can I call this deposit an amyloid deposit? Right? It's like amyloid-like. I mean, I said I'm having a perfect amyloid-like area. So when I have an amyloid-like deposit, I can definitely say which of the cancers in thyroid will have amyloid. It's obviously medullary carcinoma, right? So diagnosis here is primarily based on amyloid and it's medullary carcinoma of thyroid. Okay, I'll ask you a few leading questions regarding medullary carcinoma thyroid, which I'm sure most of you guys know. What is the origin of medullary carcinoma thyroid? Just comment in short forms or whatever you feel like. I want everyone here to comment. Like, let's assume this is like a revision session for you, right? Medullary carcinoma thyroid origin. That's the first question. The second question, what do you think is the mutation in medullary carcinoma thyroid? There is one classical mutation which can happen in medullary carcinoma thyroid. Tell me what's a mutation. So there are a few classical syndromes which can happen in medullary carcinoma thyroid. What are they? Okay. I'm sure you know the origin. The origin is your parafollicular C cells of thyroid, right? They don't originate from thyroid. They originate from your parafollicular C cells of thyroid. And the mutation, what you see in medullary carcinoma thyroid, we have a mutation, classical mutation called as ret proto-oncogene. Okay. And I'm sure you know the syndrome. Quite a few of you must have heard about the syndromes in medullary carcinoma thyroid. It's your MEN syndrome, right? MEN 2A or 2B or both. It will be seen in both MEN 2A as well as MEN 2B, right? So it's not seen in MEN 1, but it can be seen in both MEN 2A as well as 2B. Right? These are few information which have been asked previously, and I want you to know this. This is a very, very unique thing. The ret proto-oncogene, right? That's very, very important for you because there is one important concept which you have to understand in proto-oncogenes, because that's very important for me for management of these patients. For a proto-oncogene mutation to have a cancer, the mutation should be gain of function mutation or a loss of function mutation. Just tell me that alone, because with this we'll have link a beautiful concept which is helpful in the management of the patients. Proto-oncogenes will generally have a gain of function mutation, right? Because the normal function of proto-oncogene is to promote cell division. So when there's a gain of function mutation, it'll have more cell division, right? So if it is a gain of function mutation, listen carefully and answer again. Do I need one mutation to cause a cancer, or I need two mutations to cause a cancer? Because we have two copies of every gene, right? I have two copies of ret. That's how every gene in my body is represented. So is one mutation enough to cause a cancer in proto-oncogene? It's enough, right? So here only one mutation is enough to cause a cancer, right? So in MEN syndrome, MEN is an inherited syndrome, right? It's an inherited syndrome. So in inheritance means the mutation is seen even at the zygote level. That's what I call it as inheritance, right? So in MEN syndrome, I have the mutation in the ret proto-oncogene at the zygote level, in the fetus, in the intrauterine life itself, right? In the fetus itself, I have the mutation, right? Okay, one is enough. Two is required for tumor suppressor gene. For proto-oncogene, it's not two, right? For proto-oncogene, one mutation is enough, right? So can I say the fetus itself is at risk of cancer here because the mutation is seen at the intrauterine life? Yes. So when do you plan prophylactic thyroidectomy? At 10-15 years or at 1-2 years? Because the fetus itself is at risk of cancer, and we all know that fetal life is a life where I'm going to have lots and lots of proliferation of cells, lots of division, lots of growth factors, right? That's true. We already know that, right? So when do you think the surgery should be planned? Very, very early in life or later in life? It will be very, very early, right? If you remember, you in your surgery, there are few mutations where you do the surgical removal of thyroid at 1 year of life. There are few mutations, maximum you have to do it at 5 years of life. The surgery prophylactic thyroidectomy in a people in a family of MEN syndrome, if they carry the mutation, should be done very, very early. Don't wait. It's not like my other tumor suppressor genes. Tumor suppressor genes can come late in life. Proto-oncogene mutation manifests very, very early in life. Can I say FAP is also familial cancer syndrome? Yes. Familial adenomatous polyposis is a familial cancer syndrome. Familial adenomatous polyposis has a mutation in APC tumor suppressor gene. It's a tumor suppressor gene. I'll write TSG for tumor suppressor gene. Do you do a colonoscopy at 1 year or 5 years of life? I don't, because they present late in life. Because tumor suppressor gene requires 2 mutations to form a cancer, right? So all the tumor suppressor gene mutation syndromes present at least little bit late, maybe 10-15 years. But proto-oncogene mutations present very, very early. So remove the thyroid at the earliest. So if you're a surgeon seeing a patient with a familial MENS2 syndrome, 2A or 2B, please advise them to do the surgery at the earliest. That's very, very important. It's not only for MENS syndrome, any proto-oncogene induced cancer syndromes. There are very few proto-oncogene induced cancer syndromes. Rest everything are tumor suppressor gene, right? Okay, that's one thing which I want you to talk about, understand. In one more term, we discussed about medullary carcinoma thyroid, right? What do you understand from the term medulla? I'm not asking about anything extra, just what does medulla mean, that's all. Medulla in general, what does it mean? Medulla means soft. Remember this, because this might be useful for you in your real life as well. Medulla means soft. So when I say medullary carcinoma, these tumors are soft in nature. Generally a cancer, right? Generally a cancer, is it soft or hard on palpation? Cancers are generally hard on palpation, right? The general cancers, they are hard on palpation. They are not soft. So that's why medullary carcinoma is very unique. We see medullary carcinoma in your breast. We see them in thyroid. We see them in the kidney, many places, right? In general, medullary carcinomas are soft because they have very, very little desmoplasia. They have very little desmoplasia. They don't infiltrate much. They have something called as a pushing margin. These two statements are very important for me. When a tumor has less desmoplasia and it's soft, on clinical examination, you will think of a cancer or a benign condition. It's a dilemma for me, right? Generally, I'll think of a benign condition. So most of the medullary cancers, be it in thyroid, be it in your breast, be it in any organ, has a poor prognosis because they present late. The diagnosis is delayed because it's not as hard swelling. So generally a practitioner will not think of a cancer, will not jump into the diagnosis of cancer. Do remember, medullary carcinomas are soft, they have little desmoplasia. So if you see any swelling in elderly, please investigate. Don't feel them it's soft, it could be something else. Please investigate. Even for a lipoma, please investigate. Don't leave it like that, so that I can have an early diagnosis and a better management. Fine. Okay. We got next question. It's a very, very simple question. I want everyone here to answer. I see these were questions asked in NEET 2018. They do ask simple questions as well. Okay, Avinash has started it. It's A, SB has gone with A. It's stellate granuloma. Muthu has gone with 1. That's A again. Krishna has gone with A, right? See, only one tiny change in attitude I want from you guys. Whenever I post any simple question, there are more people who try to attempt it and try to answer it. Whenever it's a difficult question, there are less people answering it. It's fine, answer the question, difficult or easy. You make a mistake, that's all, right? No one is going to do anything for you. If you're worried that your friend will know that you're making a mistake, there's an option of removing comments in your Facebook live chat. Remove it, but do answer. It's very, very important. You make mistake here, you don't make mistake in the main exam, right? Cat scratch disease will have stellate shaped granuloma. These come under special granulomas. In yesterday's class, we read about necrotizing and non-necrotizing granuloma difference. They're purely special granulomas, right? So cat scratch disease, the stellate granuloma is not important for me. What happens in cat scratch disease? It will not be star shaped. It's an irregular granuloma. When we read about granuloma yesterday, we said that in the center you'll have the epithelioid cells surrounded by a cuff of lymphocytes. Generally, a granuloma will be smooth and defined, right? This is how generally a granuloma looks. It's round because of the lymphocyte collar. But in cat scratch disease, it's irregular, that's all. It need not be star shaped. It can be any shape. It's an irregular granuloma. What made cat scratch disease granuloma very unique is it's not the shape. Shape is fine with me, right? What made them very, very unique is it's about the neutrophils. So cat scratch disease granuloma can have neutrophils. That's very, very unique finding here because most of the granulomas are chronic inflammation. I won't see neutrophils at all. That's unique in cat scratch disease. They do have neutrophils. Remember that. Stellate granuloma has already come and you guys know about it. If you see neutrophils seen in the microscopy along with granulomatous inflammation, think of Castrar disease. I want you to think of that, right? Syphilis, Crohn's also is granuloma. For syphilis, I want you to remember one finding, right? I'll come back to the rest of it. One thing, remember in syphilis, the primary problem in almost any syphilis is obliterative endarteritis. That's a primary problem in every syphilis, be it primary syphilis, secondary syphilis, or tertiary syphilis. Syphilis causes obliterative endarteritis, which means it just obstructs end artery, that's all. What is the clinical manifestation of primary syphilis? How does primary syphilis manifest? A simple question, right? Syphilis will have ulcers, the genital ulcers. If the end arteries of the penile skin are obstructed or your vulval skin is obstructed, will the epithelium shed? It will. It's obliterative endarteritis, right? And very unique, they have abundance of plasma cell infiltrate. It's not anything else. It will be abundance of plasma cells and obliterative endarteritis. That's a classical finding seen in syphilis, right? It's an ulcer. It's like an ischemia, like induced ulcer. That's all. It's painless because an ischemic ulcer, if there is ischemia and something is falling off, there's no blood supply in that area. It's a dead tissue, so I won't have much of pain also, right? That's a painless ulcer, which is going to be presenting feature, right? It's not just for primary syphilis. Like I said, every syphilis will have the same thing, obliterative endarteritis, right? Let's go to tertiary syphilis because tertiary syphilis is very unique. We'll understand many things when we go a little bit deep and learn about the pathogenesis. Can anyone tell me which organs will be affected in tertiary syphilis? Any organs which comes to your mind? I'm going to discuss only one organ here. Other organ, I'll leave it to your imagination. You'll definitely know it and you will learn it as well. You can see the gamma in the CNS, and also you can see the vascular problem, right? It can affect the vessels and also it can affect the CNS. Those are the two main organs where it's going to be affected in tertiary syphilis. I'll take the aorta or the vessel for now, right? Let's take aorta. We'll see what syphilis does to aorta and the named findings and the other things as well, right? So aorta is an elastic artery. Let's assume aorta is like this. I'm just drawing the wall of the aorta for understanding. This is lumen. Aorta, like any other vessel, has tunica intima, tunica media, and tunica adventitia. Yes, it has all the three layers. Tunica adventitia of aorta has something called as vasa vasorum. I'm sure you know that. I'm just drawing a layer like this, just for understanding again. These are three layers, and my tunica adventitia here as vasa vasorum. Can I call this vasa vasorum an end artery? Is it an end artery or not? Vasa vasorum are the blood vessels which supply the blood vessels. Can I call them as end artery? They are end arteries, right? So what does syphilis do? Syphilis will obliterate the end arteries. So what syphilis does, especially in the tertiary syphilis, right? So this tertiary syphilis is going to obliterate the end arteries. So it obliterates vasa vasorum. It will block them. It will undergo stenosis. So if vasa vasorum is stenosed, it's blocked. Can I say the blood supply to the outer half of the aorta will be less? It will result in ischemia, tissue death, and necrosis, right? That will happen. It's just like that. The inner half is not a problem because inner half gets its nutrition from the lumen. Lumen has no problem. The outer half will die. Because of the stenosis, the outer half of the aorta will have a problem, right? The outer half dies. After tissue death, will it heal? It will definitely heal. Healing is always by only one mechanism, which is scar formation and fibrosis. Here also, it heals only by fibrosis formation, right? So when it heals, let's see what will happen if the same outer half heals with fibrosis. I'll draw the same thing for understanding. Lumen, okay? So this outer half is having fibrous tissue because it is healed with fibrosis. A scar anywhere in my body, is it weaker than the original tissue or it's stronger than the original tissue? Anywhere scar. Scar is weak or strong? Scar is undoubtedly weaker than the original tissue, right? Here also it's weaker than the original tissue. If it is weaker than the original tissue, can I say that can be an aneurysm? Obviously that can be an aneurysm, right? So this fibrous scar will definitely result in aneurysm of syphilis. That's first thing for me, right? Syphilis can cause aortic aneurysm. There's actually very unique findings in aortic aneurysm, which also we'll see very soon, right? It's a scar tissue happening in the outer layers of aorta. I just zoom this image. What do you think the scar will do to the inner layer? I'm having a scar tissue here. Will it pull my intima? It can have a pull effect, right? Because the scar will definitely contract. When this scar contracts, it'll automatically pull my intimal layer, right? It's going to pull my intimal layer. So what it's going to do is it'll just pull like this. It'll just pull like this. It'll just pull like this. It'll just pull like this, right? Just for understanding, I zoom the image, right? So when it pulls like this, because of the pull effect, can I say the intimal layer will become irregular. The intima will look irregular, right? So for the first person who saw this intimal irregularity on a post-mortem appearance, the aorta's inner surface, let's assume this is the inner surface of aorta, which looked like this. Lots of intimal pull, lots of irregularity. That looked for that person like a tree bark. I don't have the image of tree bark. I'll share in your Telegram group. It will be uncanny. The resemblance was beautiful. It looks like a tree bark because of the intimal pull of the aorta happening due to the fibrosis which caused due to obliterative endarteritis. That's why we call it a tree barking aorta and syphilis. That's an MCQ for you. What we forget is in the hurry to treat tree barking aorta, we forget the pathogenesis. Once I don't forget the pathogenesis, everything will fall in place. Now tell me, syphilitic aneurysms is common in ascending aorta, arch of aorta, or descending aorta? Everything will make sense. It's just science, right? I want a fact from you. I'll tell you why the fact is true. Syphilitic aneurysms are common in ascending aorta, right? That's also an MCQ for you, right? It's common in ascending aorta. Perfect, right? Now let's see why it's common in ascending aorta. Can I consider heart as the largest blood vessel in my body? Heart is definitely one of the largest blood vessels in the body, right? Perfect. So when heart is the largest blood vessel, from heart, aorta is originating. So I'm having a drastic change. From my myocardium, very thick myocardium, it's becoming a media, right? So it's a transition. Myocardium have lots of infiltrating vessels. So transition should be smooth. So in the ascending part of aorta, I have lots and lots of vasa vasarum as compared to the arch of aorta and as compared to the descending aorta, right? So in the ascending part of aorta, just to help the smooth transition from heart to a blood vessel, you'll have increase in the density of vasa vasarum. That's an anatomical problem, right? The vasa vasarum is very, very dense. So if the entire ascending aorta is totally dependent on vasa vasarum, right? So if the vasa vasarum is getting obliterated in the pathogens of syphilis, can I say ascending aorta will be the one which will be more commonly affected? Because the same density reduces when it becomes arch of aorta and descending aorta. It's a simple anatomical change, right? If this is true, vasa vasarum is an arteriole, medium artery, or a large artery. Vasa vasarum, is it an arteriole, medium artery, or large artery? We'll have to extrapolate one by one till we achieve that sense of confidence. Vasa vasarum is a very, very tiny arteriole. Okay, we'll go to one more fact. We'll prove why the fact is right. So arteriole, we have one more name for arteriole. You must have read in your first year. Arterioles are also called as what vessels? The vasa vasarum is a very, very tiny thing. It's an arteriole, fine. What's one more name what you learn for arteriole? Can I call them resistance vessels? They provide the total peripheral resistance, right? Arteriole is also called as an resistance vessels, or they provide your total peripheral resistance. Okay, so can I say arteriole will be the most common affected blood vessel in case of hypertension, which is nothing but more total peripheral resistance? True. If this statement is true, tell me which will be the common site of aneurysm in case of hypertension? Ascending aorta, arch of aorta, descending aorta. Because same vasa vasarum will be affected in hypertension because it's an arteriole. So in hypertension also, the most common blood vessel area is ascending aortic aneurysm. Rest everywhere is atherosclerosis, right? So in ascending aorta alone, hypertension is more common and your syphilis is more common because both of them target the vasa vasarum. In syphilis, it's obliterative endarteritis. In your hypertension, it's your in other words, I can call this hyaline arteriolosclerosis. That's what happens in hypertension in case of arteriole, right? Simple. Now that's where your most common questions come. Tell me which is more common now, syphilis or hypertension? That's a very, very simple question, right? Undoubtedly, hypertension is definitely much more common than syphilis because of the vast incidence of it, right? So we know the reason why ascending itis is involved. All this started with granuloma. Just remember this. Any question in syphilis, if you remember this, you can easily extrapolate one. Uh, sure, Samir, I'll repeat it. So what I was saying was arteriole or the vasa vasorum is the cause. Vasa vasorum in the ascending part of aorta is very, very dense. So syphilis causes obliterative endarteritis. By destroying vasa vasorum, it causes aneurysm more common in the ascending aorta. Same goes with hypertension. Hypertension also affects arterioles more because they are resistant vessels or resistant arteries, right? So when arterioles are more commonly affected in hypertension, the vasa vasorum is more commonly affected in hypertension. Same thing happens here. When same thing happens here, hypertension also, the most common location will be ascending aortic aneurysm, fine? Okay. So it's about vasa vasorum. Whatever damages vasa vasorum, if the pathogen is on vasa vasorum, it will definitely cause more ascending aorta aneurysm, fine? Okay. I hope I'm clear, Samir. If not, ping me in the Telegram group. Whatever doubt you have, I'll definitely clear it. Fine. Okay. Let's go to one more question. Just read the question. Tell me the answer and let's discuss more. It's a very simple one, right? Right. We need not worry much about PNH, paroxysmal nocturnal hemoglobinuria. That's option C, like most of you guys said. AMS was used as a test. It is also a test for flow cytometry. Sucrose lysis test was also a test for flow cytometry. So if there's a multiple option question, these were old tests used for a diagnosis of PNH. I don't use any of this. I don't use these tests anymore. But if it's a multiple option, which of the following can be used as a test for flow cytometry? AMS was also a test. Sucrose lysis was also a test. I don't use them anymore. Bone marrow examination is not required in the diagnosis of PNH. PNH doesn't require bone marrow examination at all. I might do if there's a complication of a leukemia, but for PNH, generally, I don't do a bone marrow examination. Fine. All three, 1, 2, and 3 will definitely form a role in the diagnosis of PNH. But if it's going to be gold standard, I'm going to go with flow cytometry, right? So there are two flow cytometries in PNH. One flow cytometry targets on CD55 and CD59, right? The other flow cytometry targets on your GPI, which will be the perfect flow cytometry. One targets on the positivity of CD55 and other targets on GPI. Obviously, the perfect one will be GPI because in PNH, the GPI is the mutation in the PIGA gene, right? So this flow cytometry was called as FLAIR. FLAIR is also flow cytometry. It's not a different test. Just remember that, right? It's same flow cytometry. I either use a 5559 or I use a FLAIR, right? FLAIR stands for fluorescent aerolysine. It's a dye. It's a simple dye which binds to the GPI, and I'm going to evaluate the presence or absence of the dye using your flow cytometry. Both are flow cytometry tests only. For the dye, what I use is different. That's how we have to go with PNH, right? I'm going to stop the discussion here. Like I said, I will be discussing more about questions. Again, we'll be consistent. I hope I'll be there with you till your NEET exam, INACD or FMG. Let's make it a routine at 5 p.m. on YouTube almost every day. And I'll do one session at 10 p.m. in the night, fine? If you're an early morning person, I'm not an early morning person. I'll try to do the same thing, whatever I'm doing in night, because 10 p.m. quite a few students have asked that they go for sleep. Maybe if possible, I'll repeat them in the morning as well, fine? Okay, do you have any doubts? If you have any doubts, do let me know. Otherwise, I'll call it a day. We don't have doubts, right? Okay, see you soon in one more class on Monday. Enjoy your weekend. Retrograde way in the sense you want MCQs to be solved in retrograde way SB. How to review GT, right? You asked me that time itself, right? We'll see how to review a GT and then we will finish it, right? See, reviewing a GT is very, very important. Whatever phase of your preparation you are, be it in the first half or be in the second half, I want you guys to review the GT, right? I want you guys to give the GT. Don't wait that I have not completed every subject one reading, so I'm not going to give a GT. GT is very, very important to do, to know where you stand, right? If I am going to review a GT, it's my original what I am going to do it. If it suits you, please do it. If it doesn't suit you, leave it. Do whatever suits you. I generally divide my errors into 3 halves. A silly mistake. My only goal is I have to reduce this. I have to reduce this to bare minimum, right? Take a notebook. Whenever you review a 200 question, I want you to categorize what group of errors they are. If it's a silly mistake, like I have not read all except, write this. Write this in your notebook. I have not read all 4 options. Or you missed something, right? I didn't read sensitivity, specificity carefully. You know the question, but you made a mistake. I don't know what is the reason. If you know the reason, write like this, right? Second half for me is memory-based errors. Okay. See, the memory-based errors, the only way to read this is you have to revise. Generally, I am not a person who is much more insisting on memory-based errors because how much ever you revise, few facts you'll definitely forget. Unless you have a very, very strong memory, it's difficult to get back to it, right? So definitely you will have memory-based errors in your main exam also. Ignore that. Maybe read with the friends. If it's a very, very dry subject with lots of information, read with a friend. That's one way you can retain them for a longer time. Ask question to your friend. You are there in a Telegram group, just throw out a question. It's not always only I should ask a question, right? You can also ask a question. Whatever you feel is difficult, PSM is difficult for you, ask questions in PSM regularly. Let other students answer so that it will help you as well as others, right? That's only one way by which I can take care of the memory-based error. The third thing for me is conceptual errors. These I want to reduce as well because this is one I want to concentrate. So what all I will group as conceptual errors is I had a case scenario. I was not able to come to a diagnosis. That's a conceptual error. As a doctor, I want you to come to a diagnosis. I don't care about a NEET exam. I want you to come to a diagnosis. I have to change this. I have to learn more because if I miss here, I'm going to miss future patients as well. That's one. Second, I don't know about this. Like, let's say you read everything in pathology. You didn't read maybe a dermatopathology much. That topic I didn't read properly. Like your hyponatremia in medicine, I didn't read properly. I didn't know the topic at all. Either I don't know the topic, I cannot make a diagnosis. Some concept is missing. This one, reread. Reread the entire topic. Like preeclampsia, I'm not able to diagnose it. Go and reread it. Antepartum hemorrhage, I'm not able to diagnose a case scenario. Go and read the entire topic. If you want, read your notes, or if you want, watch a video, whatever you're comfortable with. This should reduce. And this should reduce. If you take care of the first and third part, memory based, slowly it will definitely come. Slowly you'll improve on that for sure, right? Silly mistakes. What is the purpose of writing this down is next time when you give a GT, open this notebook wherever you're written down. Read that. Last time I made a mistake in all except, so this time I won't make it. Last time I made a mistake by not reading all the 4 options, so this time I won't do it. Not just for GT. If you're solving, let's say, 20 questions, any mini test, for that mini test also, read this once. These are the mistakes I did in last time. I won't repeat it again this time. Just before the test, read and go. And if you start doing it from now, you have 4-5 months for NEET exam easily, right? In the 4-5 months, you will have almost every silly mistake made. Read it every time before the exam. So slowly you improve. If you reduce the silly mistakes easily will constitute approximately 10 questions in any student's life. 10 questions. You know the subject, still you're making a mistake. If you just correct this 10 questions, it's plus 40 marks and minus 10 marks, right? It's 50 marks. You can improve close to 50 marks if there's 10 question error without even having extra additional knowledge. So that's first thing I want you to concentrate on. Clear as B? And then whenever you have problem with the concept, reread it. Like I said, if it's a memory-based error, post the questions in Telegram group. You can post in my group. If it's pathology related, I will answer. If it's other subject related, I'll request someone to answer for you. It's just ask questions to your students, that's all. Any question you have, ask them to students and they'll definitely clarify that, right? Okay. I hope this will help you a little bit. And thank you for your time. I'll meet you soon by Monday. Till then, enjoy your weekend. I'll not trouble you in the weekend. Bye. Thank you guys. Bye-bye.